Hey everyone, welcome to the Brain Body Reset Podcast. I'm your host, Spencer Zimmerman. Beyond the diagnosis and symptoms, there's a path to feeling better. Dive into the world of brain-body connection and learn how to optimize your health. Today I'm joined by Dr. Michael Trayford, who is board certified in chiropractic, neurology, and neurofeedback, and is the founder and director of clinical operations at Apex Brain Centers in Asheville, North Carolina. His primary focus of clinical practice, clinical research, and teaching over the past 25 years are complex brain injuries, learning and behavioral disorders with a focus on addictive and compulsive behaviors, cognitive impairment, and human performance. He currently sits on the advisory board for the Dementia Society of America and the board of directors for the International Society of Neuroregulation and Research, and serves both local and international communities through Rotary International. We are going to be talking about directing functional neurology care with QEEG and S-Loretta imaging. If you're new to the term functional neurology, this is a way to evaluate and treat a diverse range of neurological symptoms and conditions in a way that conventional imaging such as MRI and CT scan do not provide. This is a fantastic and in-depth conversation, and I hope you enjoy. Dr. Trayford, welcome to the show.
Thanks so much for having me, Dr. Zimmerman. Really appreciate it.
Yeah, I'm excited for you to be here, and I really want to talk about this topic because I know we've both seen it in our areas where this is becoming a lot more popular and common. When we look at QEEG, or other people don't necessarily know it's QEEG, they know it's brain mapping. So I'm really excited to talk about the strengths of this, the weaknesses, and really just to help people be able to explore it better and decide, hey, is this something I should consider or not? So what exactly is QEEG?
Certainly. And just to echo your, people looking into it, I've been teaching this stuff for going on 15 years now. And it's one of those things, the more I do it, it never ceases to amaze me that not everybody is doing it, because, we're looking at all things brain, and clearly looking at electrophysiology, electrical output of the brain is critically important. And we've always thought that, and it's just been such a journey. But it's a phenomenal tool. QEEG, essentially you're taking raw EEG data and comparing it to quote unquote normative databases, as you would a laboratory, blood sugar, vitamin D. You have ranges of things, and brainwaves in most of the population should fit into certain boundaries. And then there's the outliers, right? Certain times outlying is good, and certain times outlying is not so good, particularly in the populations that we see with traumatic and acquired brain injury, cognitive impairment, et cetera. So you're looking at database comparisons to see where essentially there's too much of something, too little of something, all your delta, theta, alpha, beta, gamma, all the different brain waves. We have inwardly directed brain waves, outwardly directed brain waves. So we can learn a lot about a brain by simply utilizing the database comparisons or the QEEG. And then there's certainly, if we have time, to talk about the S-Loretta imaging, which is kind of the new advent of QEEG, if you will. It's not QEEG, but a more advanced assessment. But yeah, really just getting another metric, another biometric or neurometric that we can look at to determine where somebody's at and help them along their path. And also too, with that, we talk about databases. We have TBI discriminant databases because we see so much of that. So now we can compare somewhat apples to apples versus normative population in somebody with severe TBI, which clearly there's massive differences.
Yeah, and let's kind of even step back a little bit more, because not even everyone knows what an EEG is. And if they do, they may be thinking about like seizures, because that's kind of where most people, if they're familiar with it, is where, is what they're used to. It's like, oh, well, we're looking for seizures and epilepsy. So what's kind of the difference, between that versus QEEG? Like, because if someone does an EEG, it's like epilepsy or none. Outside of that, there's really not a lot of commentary beyond that on its clinical utility.
Absolutely. Yeah. EEG primarily 95% of the time, medical EEG, which is different from QEEG in the number of channels used, because when you're trying to pinpoint the locus of a seizure, if you can in fact do that, you need, 100 plus channels to record from. A standard EEG recording is 19 channels, which we can cover the vast majority of the brain, and it's perfect for outpatient clinical operations. But yes, EEG is raw data, electroencephalography. We're looking at brainwaves. And what happens when you see a recording, you're seeing all of the delta, theta, alpha, beta, gamma, all of that living together in one recording. So what the QEEG can do is kind of pull those into the component parts. So we can look at alpha, we can look at beta, we can look at delta. We can say, you got a visitor back there. I love it. She wants to learn about QEEG. So yeah, we break it into the component parts, and we can learn an awful lot about how people can pay attention, or how they can sleep, or how they can do all the things we need to do as humans. But yes, raw EEG data. And it's interesting because as we're recording the raw data, I oftentimes spend more time looking at the raw EEG recordings, because we can learn a lot. You can tell instantly if somebody's in these alpha dominant states or theta dominant states. But yeah, we take that raw data, and essentially it's electrical output of the cortex, which they say is essentially the equivalent of a C battery. So we're not talking massive power, but we can pick up those recordings from the cortex, translate that into graphical form that we can now analyze that data with the database comparisons.
Yep. And I like telling people, when you're thinking about these brain waves, you're almost thinking about like a band. Each brain wave is a different instrument. You don't want it too loud or too quiet. If it's out of sync, out of harmony, you don't ultimately get what you want out of that band when you listen to it. And the
Absolutely.
same thing's true with the brain.
Mm-hmm.
So let's go into some of the, brain-based disorders. Like, what are some things we see, for example, because there's a lot of people, let's go into what a lot of people are using it for initially, because I know in our world we do use it beyond what many people are initially searching for. But there's a lot of people, especially with their kids, they're looking at ADHD, depression, and anxiety. So how is a QEEG beneficial for that? And maybe what are some patterns that someone would see with their brain maps?
Yeah, there's a couple of, it's been talked about that there's 6 or 7 or so patterns of, say, ADHD. And with ADD, ADHD, that's where kind of neurofeedback and QEEG started, was looking at challenges with attention and focus and impulse control. Because when somebody doesn't have enough alpha brainwave activity, they have a hard time focusing, because that 8 to 12 hertz or alpha, that mid-range brainwave, is critical for being able to attend to a situation, focus on things. So we often see a classic pattern is decreased alpha activity, often coupled with increased frontal beta activity, which is really fast activity in the front of the brain, the kind of the monkey mind, so to speak. So that's a common pattern. But then again, we can see people that have excessive frontal alpha brainwaves. So alpha activity is generated for the most part in the back of the brain, and just kind of moves forward from there. But if we see too much alpha activity in the front of the brain, that's a brain that is very rigid and not changeable. So, that could be perseveration, that could be defiance, that could be so many different things, because as you well know, ADHD, OCD, oppositional defiant behaviors, all of these things are really a continuum of disorders, and where along that line somebody falls is unique to that person. But who has ADHD that doesn't have traits of, obsessive and compulsive tendencies and so on and so forth. But yeah, that's one pattern. And that's a pattern, the decreased alpha, increased frontal beta, those are typically the ones that respond to stimulants better. So we know some psychiatrists that are titrating medications based on the QEEG, which if they're going to do the medication, it's the smartest way to do it. Because if not, it's let's try this. If this doesn't work, let's go to a non-stimulant and see if that works. And that could have dire consequences. I just had a consult with somebody yesterday who the child went on a stimulant and had really severe reactions. So, the medical world is embracing this too as a tool to titrate medications and utilize them more effectively.
Yeah. And it's definitely becoming a lot more popular and common with AI and its ability to process data. It's churning out a lot of things about what's happening. And, before we dive in a lot, because there are so many different units out there, there's just an abundance, and what's the strength and what should someone look for when they're trying to decide, like, okay, I want to go here and get my QEEG, maybe I want to do neurofeedback, like what are things that they should be looking for in a good reputable device versus something that's hey, this company followed the trend, they created stuff and they just have a great marketing campaign?
Well, that's it. It's kind of cutting through the noise, because essentially every week we're being approached with a new device, a new tool, whether it's a wearable, whether it's related to an app. We're using clinical grade, research-backed equipment, FDA clearances. For some people that's important, others it's not. But the general public, they like to know that something has kind of proven its worth as far as the FDA goes. Plus, if I collect data with the equipment that we use, because of the FDA clearances and the work behind it and the literature out there, we can utilize that for studies. We can utilize that and have it accepted by medical professionals and others that will be referring to us, versus say these plug and play systems, which I personally have some challenge with, because people hook up somebody hooks up their brain with all the electrodes, computer reads the information, tells you what to do with that. And in my opinion, that's just not my cup of tea. That's not how I wanted to start. That's not how I've continued. So this is really clinical grade EEG hardware and software that is reliable, stands the test of time, has an amazing scope and depth of application built within it. I mean, I've 15 years at this, and I feel like I've barely scratched the surface because there's so much you can do with it. But yeah, the ability to translate between professionals. I don't know if you want to talk about specific name brands, but there's a bunch out there that are really well accepted. I sit on the board of ISNR, which is the International Society of Neuroregulation and Research, kind of like the public facing entity for all things EEG, neurofeedback, neuroregulation. And there's a committee that I chair, and it's called the Neuroregulation Guidelines Committee. And we're actually looking at this point at creating lists of equipment. And this is not to serve needs for people that we like versus people that not that we don't like, but that, we don't like their equipment. This is really all about who's following the guidelines as far as the research is concerned, because most of these people are, hyper academic types, PhDs, and, they really want all the I's dotted and T's crossed. And there's many systems that fall in those boundaries. And then there's all the other stuff over here, like you said, with the great marketing campaigns that, real glossy type of thing that may, they're going to help some people. But again, they're not, we increase our probability of helping people with the higher clinical grade equipment.
Yep. And it's also just makes it very hard when people don't know, because I know you run into this too, right? People either bring you a brain map from a questionable company, or else let's say you get labs that you're like, I don't really think that testing is valid. And they come to you and they're like, but I spent money on this. Like, I need you to accept this. And it's like, we don't want you to have to spend money on stuff that may not have validity. And you've been doing this way longer than I have in the neurofeedback QEEG space. I mean, let's briefly just talk about the evolution of that. Because I mean, like when you first started doing it, it probably wasn't 19 channels, and so people get an idea of how this has evolved, because it's not a static field at all.
Yeah, certainly. And when I did start, I dove right into the 19 channel recordings. The fact is, I had no clue what I was looking at. There's clearly a learning curve, which continues to this day. But the first course I did was an immersion course. It was 8 hours a day, 5 days. A local fella here who is just one of the one of the pioneers in the field. He was the guy back in, the big universities when they used to fund this type of research, was doing it all, double PhD. And he is a true purist when it comes to EEG, meaning single site. He would look at every site independently and scrutinize everything happening at each individual site. An EEG workup or QEEG workup for him could take 5 hours, 6 hours. Nobody has that time these days, and he still does it to this day because he has associates and all. But the fact is, we have to rely on the 19 channel training, and it gives us more information. But again, going back to starting out, it was after the first year of doing it, I looked back and said, I didn't see anything that I was seeing that second year, and then the third year seeing more. And like I said, now I can just sit with the EEG tracings and almost know what that QEEG is going to look like after it's gone through the calculations along with the database. But yeah, I'm when I get into something, I go all in. So I recommend, if anybody's getting into it, going right into the full 19-channel training, because you hear about mini Qs, 4-channel, 9-channel QEEGs. I've never done that, just simply because I need to look at everything. Yeah.
Yeah, because that's even the way, a lot of the neurofeedback stuff is coming out. It's like, oh, well, there's just this one thing you've got here, right? Or there's 1 or 2 channels. It's not really thorough and in depth, So we've talked about, trying to make sure you get a good one. Now let's assume you've got a great device, right? Like, I know you use more BrainMaster. I use more on the NeuroGuide side. Both great companies. What's the strength clinically for this with the patients we see, right? We both treat a lot of brain injury, POTS, dysautonomia, long COVID. There's strokes. There's people heading to dementia. So what's kind of the benefits of running these tests? What do we gain, or that is actionable versus just like, oh, well, we have more data?
Yeah, absolutely. I mean, particularly if we just take concussion and post-concussion syndrome, the most common thing. One of the things we see, Barnon, and I have thousands and thousands of studies and hundreds of S-Loretta imaging recordings, real-time imaging of the brain as the EEG is going along. And we can start to pull out component parts. We can look at frontal lobe, or we can get real specific and look at Brodmann area 9. We can look at really anything, networks, default mode network, et cetera. But if somebody's had a concussion, we know there's inflammation involved. We know there's breakdown in, epithelial cells in the gut, endothelial cells in the blood-brain barrier. There's inflammation. And what this presents as, even though we can't look at that EEG and say, that's inflammation right there, we can certainly see the hallmarks, and that's excessive slow wave activity, particularly theta brainwave activity. And probably 9 out of 10 EEGs we run on concussion patients are showing massive amounts of theta brainwave activity, which is really hard to deal with because, it's really more of a metabolic issue. So all the neurofeedback in the world is not going to clear that smoke. So we have to look metabolically. We actually, quick aside, I presented a paper, in-house clinical study we did with 10 people, post-concussion syndrome, put the caps on, recorded. I think 9 of them had excessive theta activity. We got them on a vibration plate at 30 hertz for 10 minutes, waited a half an hour, re-recorded, and we saw profound reductions in theta brainwave activity. So we were using frequency-based modalities, but the fact is, vibration for 10 minutes did what it would have taken probably 6 weeks of neurofeedback to do. Now, I love neurofeedback. It's a phenomenal tool, but it's knowing when and where. So we see those hallmarks enough, like the excessive theta activity, that we can go ahead and just, it's kind of like a guilty till proven innocent, but now we look at the labs, we look at everything else, and we say, all right, that's what this person has going on. And, we may introduce neurofeedback, but we know the other things are far, far more important.
Yeah, and I think that, is going to intrigue a lot of people, but also kind of confuse them, because I think the majority of people that have QEEG and neurofeedback, that's kind of their one thing that they're doing. There's not many people like you out there who are like, hey, I'm going to take your QEEG and I'm not necessarily going to use neurofeedback to train it. And if I do, that's going to be a small part of what I do. There's going to be other modalities. So you've talked about vibration plate. What are some other modalities that you like, that you see when you actually use it? It can change some of these brain waves.
Laser, number one. I do some talks, where we actually have people set up real time with the EEG. We're watching the recordings. We obviously have their history. We can do some calculations. Sometimes we'll get them the night before at the continuing ed seminars that I do. And then we'll do real time. We'll just have them in the chair as a recording. We know, say they have, we had one that was a TBI case, an older TBI case, but all kinds of, obsessive compulsive tendencies, perseveration, even getting into dissociative types of situations. And she had massive amounts of beta in her posterior cingulate. I mean, critically important for self-regulation. That thing was just screaming. So we just went in and focused. We actually did red laser first. We weren't making much of a dent in it. And we mess around with the frequencies, because if she's got too much beta, we don't want to be running that laser at 30 hertz. or higher. So we were going a little bit lower. And then we switched to a green laser and actually saw some massive changes. So it helps us, just like the medication, it helps us titrate the delivery of the intervention, in this case, laser. So yeah, we've got so many studies looking at real-time impacts of laser on brainwave activity, and it's really, really cool. And of course, some of it may be temporary because these conditions are hardwired. The brain has gotten used to it, maladaptive plasticity. But like anything else, repetition. We do things over and over again. We couple that with, say, the concussion case that's dealing with profound inflammation, hyperbaric oxygen therapy coupled with laser therapy. Now we're having multiple anti-inflammatory benefits. Now we start taking some of the sugar out of the diet and get them better hydrated, get them sleeping better. Everything's going to kind of chip away at that, to the point of, people having that as the one tool in their toolbox. That is the case. Most people practicing neurofeedback and doing EEG are doing just that, and possibly counseling and things like that along with it. But I know some incredible practitioners that are so laser focused in what they do and so passionate about what they do. That one tool becomes much more powerful than a million tools in a clinic with somebody that doesn't know how to use them that well. So it's not about how much you have, it's about how well you use that tool. Kind of like a chef, you can have a brilliant chef with one knife that can knock something out of the park, and you can get somebody else with the best knife set ever, and they're just gonna torch that dinner.
Yeah. Now, we keep talking about metabolic, and that keeps getting brought up. What are some of the things that you may see in labs that could impact the QEEG? And you're like, hey, you know what? I see this. Maybe that's a player as well.
Yeah. I mean, but first we go to the gut. We have to look at the gut microbiome. We have to see if people are, not absorbing fats, if their, microbiome is disrupted. We need to look at other inflammatory markers, various immunoglobulins, the MMPs. We need to look at these numbers that tell us there's indications of inflammation, because if there's inflammation in the gut, there's certainly inflammation in the brain, particularly in concussive cases and traumatic brain injury cases. So, that's one tool. We always go right to the C-reactive protein. So there's, basic markers and more advanced markers we can look at. But the cool thing is we have seen profound improvements in post-concussive symptoms, and particularly more what would be considered the metabolic aspects of it, the brain fog and fatigue and things like that, with gut laser. So we do a lot of gut laser. We do a lot of transcranial laser, but we do a lot of gut laser. And sometimes we can have a bigger impact working through the gut. So, it's just kind of a sampling of things, but that's our approach.
Okay. Yeah, and that's something, most people don't necessarily think about, is lasering over the gut. And even though more and more people are talking about the gut-brain axis, it's still very much from from the brain, you can do some basic vagal stim, and then from the gut, it's more probiotics, it's short-chain fatty acids and other things like that, versus stimulating the gut using laser, whether it's red or, we've got the green and violet that I know you've got as well. So.
Absolutely. And I just encourage anybody who's working in that space or seeing patients that have had concussions, just Google, concussion and epithelial cells in the gut, and, you will be blown away by the amount of information out there talking about. Then you look at the power of laser and what it does, with cellular energy production and, all the good things, decreasing inflammation, a lot of synergistic benefits with hyperbaric. It's kind of a no-brainer, no pun intended, to deliver these therapies as metabolic therapies.
Correct. Yep. Out of curiosity, and I don't know if you have the device, but are you familiar at all with using maybe QEEG as a way to direct transcranial magnetic stimulation therapy?
So yeah, we know some people that are doing that for sure. We do a version of, much, much lower intensity. A lot of what we do, be it vibration, be it laser, low level, low power. The fact is, again, our brain is not that powerful. It's powerful in what it can do, but from a true power perspective, it's not. So sometimes too much power is not the best thing. We know a lot of people that have had amazing benefits with transcranial magnetic. It's a really powerful tool, but it's a very powerful tool. So we have to be real careful. We do micro Tesla. So we're using electromagnets on the skull primarily, and utilizing QEEG to direct those applications. Where do we want to stimulate more gamma activity in somebody who's dealing with dementia or autism? Or do we want to, again, enhance alpha or SMR, that sensory motor rhythm, which is critical for attention, focus, impulse control, brain-body connection. So yeah, we certainly do that to direct the type of electromagnetic stimulation we do, but it's not TMS as most would think of it.
Yeah. Okay. Now, whenever we've talked mostly about other things that can be done, but when we look at neurofeedback specifically, is there a group of individuals that you're like, wow, they respond really well? Like for me personally, I see it works really well with kids compared to the adults I'm treating with it. But what are you seeing?
Really across the board. And I think because it's in concert with everything else, very rarely are we doing strictly neurofeedback protocols. 1 out of every 50 cases we see, we might do strict neurofeedback. Or, if there's, limitations of finances or time or things like that, because we require people to be in our office 5 hours a day. And if they simply can't do that, we can do a 20-minute neurofeedback session. We still do it at a fairly high frequency, and that's another discussion. But I would say, and, this kind of gets into the esoteric thing, but, we understand brain-body connection. The more rooted one is in their physical body, the more capable they are cognitively, emotionally, psychologically, et cetera. So we're seeing we work with treatment programs that are dealing with people that have addiction that cannot even go through individual or group counseling. They're so disconnected, dissociated. And we find, if you've heard of SMR protocols, sensory motor rhythm protocols, where we're training that 12 to 15 hertz sweet spot up, and we see people becoming more rooted in their physical body. And we can measure that by them being able to do complex motor skills more effectively. And, their motor timing improves and their gait and all of these things simply by doing these types of neurofeedback applications. So concussion, post-concussion, addiction, certainly ADHD. We don't see a lot of ADHD kids. We're seeing more ADHD adults, and they're typically peak performers, high-level athletes and executives, and they do really, really well with it, to the point that we're often getting them smaller 4-channel neurofeedback systems they can use at home to continue the training.
Nice. So whenever, once again, we're looking at this, right? QEEG brain mapping is a component that a lot of people are looking at. They're bringing it in. Most places it's kind of a standalone. We're using it as more of a component. What do you see, right? We've talked about vibration, laser. Are you also seeing what I'm seeing, where, through vestibular rehab and oculomotor training, that we're getting changes in people's QEEGs?
Big time, yeah. I'm glad you asked that, because, we look a lot at superior parietal lobule on S-Loretta imaging. When you have a brain map or the QEEG, you're pretty much looking at everything. It's a summary of the amount of time you recorded, but essentially it's a static image of the whole brain. You can't pull out component parts. With S-Loretta imaging, the low resolution electromagnetic tomography, we are able to really pull things apart. So we can pull out superior parietal lobule, which has a lot to do with understanding where we are in space. So we correlate that with somebody's dynamic posturography or measurements of balance, and they improve concurrently. They go one. You can't really have one without the other. So if somebody's balance is improving, their deficient output in the superior parietal lobule will be improving as well. So there's areas like that we can look at, but clearly frontal brain is critical for balance. A lot of people aren't aware of that, but attention and focus are critical elements of balance. So as we're seeing, the monkey mind decrease, the excess frontal beta activity, we're also seeing people get more in their body. So, more easily getting through their environment and their space. I have, the S-Loretta imaging recordings I was telling you about. I have a lot of them in that space, looking more at the physical problems as related to what's happening up here electrically.
If you're finding this information valuable, please share this podcast with others and give us a 5-star review, as that is the only way this podcast grows. Please continue listening and keep enjoying. Nice. Yeah, and I mean, I know we kind of keep rehashing this from different angles. I just want people to really know that there are so many different ways to change a QEEG in a brain map. And let's say someone just wants to do neurofeedback initially, because once again, I know we both get plenty of people who've done that before they even come in. And I know it's also going to vary on the unit, but like, when should they say, maybe I'm missing something else, right? Like I came in, I went in with this provider, they did neurofeedback. We did 5 sessions or 10 or 15, and I'm not really seeing the results. When should they be like, look, honestly, you're just on the wrong path, versus you need to keep going? Because a lot of people just keep going when they don't know that they should actually turn around.
Yeah. And there's so many elements to that. Number one, just the placebo effect of somebody going in to do something positive for their brain. That's a catalyst, but that catalyst wears off very quickly. And, I hear you saying 5 or 10 sessions. We got people coming in saying they've been through 100 sessions, 120 sessions of neurofeedback. And, and this is not, I think it to myself. I don't say it to them. I'm like, why? Why? Like there had to be a point where you said this is not working. And more importantly, there had to be a point where that practitioner said this is not working. So we often look at 10 sessions, reevaluate. I do a lot of mentoring with providers, mostly out of the country, in Croatia and some other places. And I was just on a session yesterday with a doc in Croatia, a medical doctor, and she, it's interesting because we've really kind of taken down their number of training sessions, which, from a business perspective, some people would say, well, that's not job security. But the fact is, you get them out quicker, there's going to be more people in the door faster. So we had them set up on 10 sessions, reevaluate. And the fact is, if things are moving along subjectively and objectively, how they can look at it, if they keep doing the QEEGs, then you stay the course. I mean, the fact is, a lot of these are hardwired maladaptive problems, especially the learning and behavioral ones. So some of it can take some time. But yeah, I wouldn't have anybody go beyond 20 sessions without taking a good hard look in the mirror and say, what are we missing here? And certainly that could be other things. Again, if that's all you have is the QEEG, then you do another one and see where things are moving. Are you changing the number of standard deviations that something is outside of the bell curve? If so, and even if there's no subjective improvement, then you can still stay the course there as well for a period of time, but certainly not 50, 60, 100 sessions.
Yeah. Yep, because that's definitely an issue. Now, I know we've been mentioning S-Loretta quite a bit, and I want you to just kind of explain that software, because it's one that I used to use, and I don't necessarily use it now, but it's got a really nice way of allowing the provider to really dissect into specific parts of the brain and to look at what's happening there and then communicate that with their patient. That honestly, most of the other softwares out there just don't have available.
Yeah, absolutely. And it's looking at things a little bit differently. It looks at current source density, so the amount or volume of current in an area. And these areas are little tiny boxes, or voxels they call them. There's essentially hundreds of them in the brain. So it's akin to functional MRI, although functional MRI is more metabolic. The S-Loretta imaging is more electric. So we're looking at this density in areas, and as we're looking at the overall picture, we always start looking at the whole brain. Like Google Earth, you got to start way up, and then you start coming in. So I do this all the time as I'm recording, because, and this is another thing, some people, they record an EEG, they put the cap on, everything looks good, they hit the button, they leave the room. If you leave the room, you've missed everything, because that QEEG report may not have a lot of what you're going to see on the raw EEG, but also the S-Loretta imaging. So you can basically now, if this person, it could be as simple as, okay, this person had a hit to the right, they took a softball to the right front brain, or the right front head. You can just home in on that right frontal brain and see what's happening there. Sometimes you'll get it, sometimes you won't. But also too, if somebody's dealing with attention and focus issues, or addiction and compulsive behaviors, you pull out the default mode network. So now you're looking at, parts of the back, parts of the middle, parts of the front, central executive network in people that are dealing with dementia. We're often seeing the anterior aspects of the central executive network are very, very low in beta activity. So we're just going in, looking at the component parts. If people follow are familiar with Brodmann areas, that's a whole nother realm that opens up, because now you can get hyper specific. Again, dorsolateral prefrontal cortex, area 9, visual processing areas, people that have had brain injury and they're dealing with cortical vision impairment. As long as they're cognitively capable, we can do neurofeedback with them to help improve the electrical output of visual processing areas, so that hopefully it can open up their vision a bit. And we've seen that happen. We've seen people get more peripheral vision with neurofeedback more than other modalities, or coupling neurofeedback with laser at the same time in those areas. So yeah, it just opens up a whole new world, and the specificity is just unbelievable.
Yeah, and that's very interesting, because if I think about some of the most frustrating patients I treat, it's the people who so we both perform video oculography where people are wearing goggles and we're recording everything they do, but they're the people who they ace their eye movement test, but they tell you they feel horrible. They're like, but my eyes hurt so bad. And I'm just like, but you're acing the test.
Yeah.
And they usually try to beg me to do rehab. And I'm like, I mean, we can trial it, but I really don't see profound results. Maybe I get like 10% little bumps, but I don't get anything more profound. So are you seeing cases like that? Those are the ones that you're kind of describing, or a little bit different?
Yeah, I mean, we do certainly see those. We have one this week, as a matter of fact, where everything, most everything diagnostically is way up here. I mean, looks really good. But then that said, after 2 weeks of immersive care, we're seeing massive shifts in the EEG. And this is one of those situations where, it's a patient education thing. It's not like, a lot of people, it has to get worse before it gets better. However they say things, the way we talk with people about that is your brain has taken a long time to learn the problem that you have, whether it's a balance problem, visual problem, whatever, especially if there's concussion or something like that involved. So even though the data is getting better, we use that, and we often see that over time, from a longitudinal perspective, talking with these people after the fact, that the symptoms start catching up to the objective improvements, meaning they're coming down. But it takes time, because maladaptive plasticity has a really bad dark side. And, and that's what we see every day is maladaptive plasticity. So, the patient education component is huge, because, people want those results right away. And in these cases, some of those cases you're speaking of, they can take time. And that's where most people just give up and, wash their hands of it and say, I can't do this. And, certainly it's good to refer out and collaborate, but these people have usually been to probably 10 or 15 other people that have kind of washed their hands of it too. So, oftentimes, as we're the last hope. So we want to stick with it for a reasonable period of time. But as long as we're seeing those objective improvements, it leads us to believe there will be subjective improvement to follow.
Okay. And then, when we look at QEEG expanding, I know they keep trying to, some of the lectures I've heard, they're trying to compare it to like, okay, well, it's cheaper than a DTI, right? Like, here's some of the ways that we can use it. What are you seeing as far as flow metrics with how different parts of the brain are communicating? Because, for example, I do TMS, and Stanford, and I'd have to go back and look at the research exactly, but they were looking at flow metrics between like the anterior cingulate and the insula, and based upon how that traffic was essentially moving, they could use that to predict who was actually going to respond to TMS versus who wasn't. And I think that's a lot, so what are you seeing on that?
Well, that's just next level stuff right there. It really is. We look at certainly coherence factors and phase lag, these things that determine or basically infer what's happening with regard to transfer of information from spot to spot. Whether it's, EEG point to EEG point, F1, F2, that kind of thing, or different brain regions. So there certainly is so much coming up there. It really is so new. I'm not an expert by any means in that avenue of things, but I'm really excited to see what's coming down the pike, because just like using even the static QEEG brain maps to titrate medications for kids with ADHD, if they're going to go that route, it just makes a lot of sense. But again, what happens is, that rabbit hole is getting deeper and deeper and deeper, which is a good thing. But the fact is, this day and age, nobody wants to, people want to look in that rabbit hole. They don't want to go down it. because there's an app for that, because there's something. And, it's scary to people to think I'm going into this thing where I'm going to have to study for however many more years. And I get that, I really do. But certainly we'll be following that. And I'm glad you brought it up. It just, it's still so new. I can't even really comment on it at this point.
Okay. And then as far as new stuff coming, so there's that, which is really developing. Is there anything else that you're seeing clinically, or that, since you're on the advisory committee, that you're seeing that they're talking about that's like, wow, this is really exciting. Now we need to see more, but this could maybe be game changing in the next 5 to 10 years for many of these people that we kind of see on a day-to-day basis, from the concussions, the strokes, to those heading possibly to dementia, to neurodevelopmental disorders, and others in kind of that segment of the population.
Yeah, I think the biggest thing right now that they're talking about, and some people are doing, is actual imaging of the cerebellum and operant conditioning of the cerebellum, which was once thought impossible, because of obviously very different cortex. So that is really what's most promising to me, because no matter, at the end of the day, everything we see has a cerebellar component, has a brainstem component. So if we can actually train that, we have all kinds of ways to train the cerebellum, doing fine motor skills, all kinds of things, vibration, but using neurofeedback as a tool to train the cerebellum, that especially for spinal cord injuries, and where just nothing is getting up and through that area. I just think and addiction, again, brain body connection, everything is cerebellum right there. And when we can start to train that, it's going to be a good day.
Nice. All right. And then briefly, because I know we've been mentioning neurofeedback a lot, can you briefly explain what that is? Because I know it confuses a lot of people. They're like, wait, so I sit there with a cap on, or I sit there with something on my head? Like,
yeah, it's essentially, so here's the thing, you have two types of people that can cognitively understand instructions and others that can't. So at the end of the day, people that can't cognitively understand instructions, they're not a candidate for neurofeedback. I see people doing that, even with people in vegetative states, and we've tried it and done it, and we've not seen any movement. So, we move to other things. But at the end of the day, it's operant conditioning. So your brain will go after what it perceives as being beneficial, right? Our brain is about, just, seeking benefit and avoiding pain, essentially, for better or for worse. So there's visual, auditory, and other types of feedback, but primarily visual and auditory, depending on what type of training you're doing, whether it's eyes open, eyes closed. And there's different reasons for that based on the maps and based on the presentation. But we're listening to certain parts of the brain. It could be 1 point or it could be all 19 points. And as people are meeting certain criteria, for example, if they have too little alpha activity, we want to bring that alpha activity up. So we tell the person, every time your alpha activity comes up, or every time your attention and focus comes up, because that's what alpha does, you're going to see a flash or hear a sound. And then what happens is, okay, that's good. I want to go after that. The brain wants to go after that. So every time they see and hear that, the brain is just essentially wanting more of that. That's the operant conditioning that occurs. We have to be careful, because we don't want, especially the hyper analytical types and all. Now they're trying to drive the neurofeedback. They're trying to make this a heavily cognitive process. We find when people are in more of a mindful state, if they're simply focusing on their breathing with having that understanding cognitively of what that's all about, things just go on autopilot. And then there's fatigue points too, like there would be with, working out a muscle. We see these percent reward, they call it. There's reward is the sounds and the lights when you're falling within the parameters that are specified. And then we see people kind of climbing this hill and doing better. And then oftentimes there's a drop off. And that's where, just like studying too much or anything like that, that's where it becomes more counterproductive. So same thing. A lot of people will set people up on neurofeedback, press a button, leave the room, and do a 40 minute session just because, they advertise as 40-minute sessions or 20-minute sessions. We could start people on a minute or two and then pull the plug and go to the next thing, simply because that brain is so fatigable, and we don't want to treat it in that fatigue state, because we know neuronal fatigue is not a good thing, as muscle fatigue would be. So it's really just that simple understanding. You see and hear something, you're getting more of what it is we're looking for. Yeah.
Yep. And I'm glad you mentioned the fatigability, because I know in different Facebook groups, people are like, oh, neurofeedback was great. And others like, it made me so much worse. And it really is that metabolic capacity and the fatigue level of like, look, sometimes you just can't do much. It doesn't mean it was the wrong therapy per se. It means it just wasn't executed appropriately for you. It was done in excess of what you could have handled.
Right. And somebody I was just mentoring, they said, well, we advertise 20-minute sessions. And I said, well, don't do that. I said, what you want to do is advertise a session and explain to them, just like working out. If you haven't worked out in 3 years, you're not going to go to the gym and go all out for 20 minutes. You're going to hop on the treadmill, walk a little bit. You're going to hopefully outside walk a little bit, maybe, lift up, get on the machine so things are controlled. You're decreasing your risk for injury. You're not going to feel like, the next day, like you never want to work out again. And that's what can happen. Somebody, especially in the early stages of neurofeedback, if you hit those fatigue points quickly, they are not going to want to do that. And then they're going to be told they need to do that. And then they're going to have an adverse reaction, because adverse reactions are not uncommon in neurofeedback. But I have to say, in our clinic, we hardly ever see adverse reactions, because we're so in tune with this, with metabolic rate, neurological fatigue, and we do just enough and don't go over that edge, because once you go over the edge, then you're backtracking.
Yep. And that's definitely something, that's very different that you see in functional neurology clinics, because of our approach of trying to respect the fatigue and the metabolic stability, essentially, of the system, compared to using more of a physical therapy approach to the brain, of being like, oh, it's okay, your muscle, like, it's not torn, we just got to push through to discomfort, because what works good for one system in the body can actually be highly detrimental to the other.
Mm-hmm. Yeah, we have good friends in a physical therapy clinic right across the way, and that's how it goes. That's what you have to push limits sometimes to get stronger physically. But we have I was thinking about putting up a sign like "No pain, no gain" does not live here, because it's so important. Once people understand it, you see the light bulbs go off, and they're like, all right, that's why I've been so screwed up for so long.
Mm-hmm. Yep. They say that all the time. Like, you're right. Like, that is why I didn't.
Right.
Is there anything else we should talk about when it comes to QEEG, additional modalities that can be layered on top?
It's really just the brain map. It's a director. It really helps tell us where we can go. So, frequency-based modalities, people hear that and say, oh, my frequency-based, that crazy chiropractor. But, at the end of the day, light, electricity, all the different things, everything carries a vibration, everything carries a frequency, and we can utilize those frequencies. So using that as a map to direct your frequency-based therapies, even the frequency of exercise and movement, having somebody move it, at 1 hertz versus 20 hertz. It's really important to understand those connections. So, I think that's a big deal in understanding as a director, and really, building on that, I just want people to not be afraid, because again, it is, it seems scary. It seems like, oh my goodness, how am I going to learn this? But just little by little, you just start doing them like anything else. We didn't get good at what we were doing by doing it once or twice. You got to do this stuff over time. And then you just start to see things you have never seen before. And it's such a cool experience when you get to that point.
Yeah. Awesome. So this has been amazing. So if someone want to learn more about you or to work with you, where should they go?
apexbraincenters.com. That's our website. It's pretty robust in terms of educational material, talking about the program. We have 150 blogs on there for all the different things we see. Lots of really good videos. Our patients, I'm sure as yours do, love to tell their story, and we don't cherry pick the best outcomes. These are fairly relatively routine cases. Instagram, we have a really a great community on Instagram, large community there, and we're just posting, we're just posting a lot educationally and story-wise, so people can see. The biggest thing is just, hope is there's a massive hope deficit in so many ways right now in this world, particularly for people that are struggling. They've been written off by their providers, their families, and themselves sometimes. But really just having people being able to get some little aspect of hope reignited can really start the process to them getting better. And most people just don't understand that resources like this exist.
Yeah. Thank you so much for being here, and look forward to doing this again sometime.
Awesome, Dr. Z. Thank you.
Yep. If you have found the material valuable, please subscribe to my YouTube channel, Dr. Spencer Zimmerman, and leave us a 5-star review on Apple Podcasts or where you normally listen to podcasts from. If you would like to work with me, visit peakbrainandbody.com to learn more. You can find me on YouTube, Instagram, Facebook, or TikTok, all with the handle Dr. Spencer Zimmerman. I'm also on X with the handle Dr. S. Zimmerman5. This podcast is for general information purposes only and does not constitute the practice of medicine, nursing, or other healthcare professional services, including the giving of medical advice. No doctor-patient relationship is formed. The use of this information and the materials are to be used at the user's own risk. The content on this podcast is not meant to be a substitution for medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice for any medical condition that they have and should seek the assistance of their healthcare professionals for any such conditions.